Hi, everyone. Welcome to the RCDP PFDD session. I'm Sanjot Sangodkar, and my colleague Tim will be joining us virtually. Unfortunately, he wasn't able to make it and travel down here. I first and foremost want to just say thank you all so much for having us and for taking the time today to be with us today. And so with that, we'll get started and look forward to hearing from you all soon.
Thanks very much, and good morning. My name is Tim Franson, and along with my colleagues Dave Zook and Sanjot Sangodkar, would like to welcome you to this patient session for the community involved in Rhizomelic Chondrodysplasia Punctata. We're so pleased to be here today with the RCDP community as you come together to share experience with the condition and views about current an incredible opportunity for FDA, for therapy developers, about what is important to those living and for those who care for them. Our firm has considerable experience working with FDA and other advocacy groups, members of this sort, to advance patient-focused solving rare disorders. And so we're excited to be able to share that experience with you today. And I want to remind all, and we'll be later, this is a hybrid meeting where folks are in person as well as online. And several of us were quite disappointed that the events of yesterday did not, were just a few errors in a line of computer code in a cybersecurity program. And it's very similar to what we see for changed letters in the genetic. Big differences, as we all know. And we'll be talking about that and how to make big differences in impact for developing therapies and FDA understanding. The opportunity this morning to provide some context to the session and to provide a preview for you of the proceedings that we'll anticipate over the day. We'll begin with opening remarks from Melinda Holliday, followed by presentations for our two guest speakers. And I want to also highlight appreciative of their engagement and involvement. After Melinda's talk, we will have presentations from our two guest speakers. First, my colleague Dave Zook will provide an overview of patient-focused drug development. And then Dr. Michael Bober will provide an overview of RCDP. To note there that Dr. organizers to represent the community's top clinicians. Then we will go over the overview of the discussion formats and how panels and polling, which you'll all be involved in, will operate in harmony with. Then we'll move to our first discussion session on the symptoms of RCDP and the daily impact of that on those children, families, your families. Following that first discussion session, lunch, and then return promptly at 1 p.m., where we'll move to a second session. And that will be a discussion session on views relating to approaches to treatments that are currently available and those future treatments that might be desirable for all of you involved. Finally, we'll plan to close the session promptly at 2:30 p.m. so that you can plan accordingly. The desired outcomes are to be, and that will come from the panel topics and related voice and polling exercises. So we've helped refine this. Bring that along with what is discussed today to provide FDA and therapy developers the very direct patient voice to hear what it's like to live day to day and hour to hour with RCDP, the complexities of this process, the concerns about disease symptoms, managing RCDP, and what you desire for meaningful treatment improvements. All of today's activities and input will be summarized in what's called the report. This voice researchers, drug developers, and regulators going forward, so that what we're doing today should be a foundation. And in today's session, it's my pleasure to introduce Melinda Holliday, president of the board of RhizoKids International, who'll be providing some welcoming comments remotely. Unfortunately, Melinda is unable to join us today in person due to complications with her son's health status, but she did pre-record her opening remarks. So without further ado, we'll hear from Melinda.
Hello. Welcome to our RhizoKids International patient-focused drug development session. We are so excited for this opportunity to offer a small glimpse into the day-to-day of living with Rhizomelic Chondrodysplasia Punctata. I am so sorry that I am unable to be with you in person today. As most of you know, our son Ethan has been admitted to the pediatric intensive care unit at our local hospital. At this time, he is on a ventilator, but we are hopeful that we will soon be weaning him back to his home regimen so that we are able to return home soon. We all know that this is a very real part of our RCDP journey: unexpected hospital admits and extended stays inpatient. This is one of the very reasons why we're giving 100% and trying our best to bring a clinical trial to fruition. I'd love to share a little about how RhizoKids made it to this place in time. 17 years ago, there was very little information on RCDP, and what we did find was very outdated and honestly crushed our spirits. For 6 months, we walked this journey alone, unable to find any other families living with the same diagnosis. In our search to find answers for Ethan, we finally found 4 other families and came together to form RhizoKids International. We had no hope and no treatment options. And as a parent of a child with a fatal diagnosis, I can think of no greater heartache than knowing that there is nothing that you can do to help or save your child. We have searched for help in many places and tried to find a thread of hope for the future. We never asked for this, but we never shirked the responsibility that came with this life or this diagnosis. We knew when we set out to form RhizoKids International that more than likely anything we found or any clinical trial that came along would not come in time to save our children, but we were still determined to give it everything we had. Out of the 4 families who started this journey together, there were 7 children affected by RCDP. Over these last 16 years, we have lost 4 of those 7 children, but we still work together because we know that there are more families and children who will receive this horrible diagnosis. And our goal is that no other family will ever have to face this alone, like we did in the beginning. Our goal has always been to find a safe treatment for our children and to be able to offer it to other families as they receive their diagnosis. This disease is so rare, and that makes it so hard to find a treatment. But our hope is that everyone is able to look at children affected by RCDP and see their worth and know that they deserve every chance to live the best life they possibly can. We have suffered immeasurable losses through the years, and with every loss comes the heart-wrenching reminder of our reality as parents of RhizoKids. We live in a constant cycle of fight or flight, of endless self-imposed research in the attempt to try and find answers to the unanswered questions, and we are constantly looking for any small glimpse of hope for our children. We live our lives boxed inside of a diagnosis, but we dream of a life where we can lay our heads down at night without the weight of the world crushing us, without fear dominating our thoughts, and without the worries that our children won't live to see another day. Our children are warriors, and we have watched them fight through the unimaginable, and because of that, we are able to fight for them. We are a team, and our children are the core of who we are. And as president of RhizoKids International, and the mom of a fierce RCDP warrior, I want to thank each and every one of you from the bottom of my heart. We are going to change history and help forge a new path for all of the families who come after us. We are Rhizo Strong, and today we raise our voices to be heard loud and clear. Thank you all.
We thank Melinda for taking the time to welcome us today and for MedLife Discovery's support of this session. Certainly a very visually moving reminder of many with unplanned emergencies. So quite moving. Now I'd like to introduce David Zook, Chair at Faegre Drinker Consulting and a real pioneer in this area, giving an overview of patient-focused drug development and its role in medicines for rare diseases. So Dave.
Hello, everyone. My name is Dave Zook, and I'm with Faegre Drinker in Washington, D.C., where we focus on life sciences law and regulation. For the past 3 decades, we've worked with patient organizations like RhizoKids and industry to help advance new treatments, particularly for rare diseases. Much of our work in the last 10 years or so has been on the strategy known as patient-focused drug development, or PFDD. Put simply, PFDD is an approach where the perspectives of people living with diseases and conditions are brought directly into the therapy development and regulatory decision-making process. To many people, that may seem obvious. Of course, what matters to patients and caregivers should be the focus. But that's not always been the case. Fortunately, Congress, FDA, industry, and stakeholders like RhizoKids have embraced PFDD as a way to encourage more effective and efficient development of new treatments. At the center of this work is using reliable ways to identify and apply the insights around what matters most to those living with a specific condition. Under the 21st Century Cures Act, passed into law in 2016, FDA was directed to create a set of guidances that lay out the pathway to collect these patient perspectives, or what we often refer to as patient experience data, and to explain how the agency will use it in reviewing possible new therapies. These and inform the assessment that FDA makes of the benefits and risks of any new therapy. Today's PFDD session is a key step in this direction for RCDP. We're following a format that, again, Congress endorsed and FDA refined to help drive this process. FDA officials know there are significant gaps in their understanding of complex and serious conditions like RCDP. The PFDD session is designed to help fill in those gaps. It's important FDA understands the patient perspective as you and your families are the experts in living with RCDP. FDA plays a critical role in drug development, but they're only part of the process. The agency promotes public health by evaluating the safety and effectiveness of new treatments, but they don't actually develop the drugs or conduct the clinical trials. That's done by medical product developers, healthcare providers, federal partners, and others. So the PFDD work we're doing here today is for the benefit of all of these stakeholders. Bottom line, the PFDD session and the resulting Voice of the Patient report that captures your perspectives and will be made available to all are an opportunity to ensure that FDA, industry, clinicians, and others hear from you directly on the RCDP symptoms that impact your daily living, your experience with the current treatment options, and your desires for better therapies. Today's discussion lays the cornerstone for patient-focused drug development in RCDP. We're building a foundation that the FDA and companies will use for years to come as true partners with you and your families in the pursuit of better care. Thank you for allowing us to be part of this important work.
Dave, thank you very much for your comments and giving us this important perspective on how from today will be used and how Congress and FDA expect us to be able to capitalize on this and build a foundation for rare diseases today and tomorrow. I am now pleased to introduce Dr. and a geneticist in the skeletal dysplasia program at Nemours Children's Hospital of Delaware, who's had experience in treating children with RCDP. Bober will give an overview of the symptoms of RCDP, as well as current treatment approaches. So without further ado, we'll hear from Dr. Bober remotely.
To thank RhizoKids International for the opportunity to speak today in this very important patient-focused drug development session. My name is Michael Bober, and I am a pediatrician and a geneticist who sees children with RCDP at Nemours Children's Hospital in Delaware as part of the skeletal dysplasia program. I've been involved with this community for many, many years. Here are some disclosures. So what we'd like to cover today is what is RCDP, what are the current standards of care, what are the unmet needs, and what are the opportunities for progress. So what is RCDP? Well, first, in the name RCDP began in 1971 when Dr. Jürgen Spranger and his group described a rhizomelic form of chondrodysplasia punctata. Now, chondrodysplasia punctata is a radiographic finding which has been recognized for many, many years. And in this publication, he described a new patient as well as 33 patients going back at least to 1936. And as I said, chondrodysplasia punctata was a well-recognized radiographic form with a large, and with this description, he was able to separate RCDP from the remaining chondrodysplasia punctata patients, which were then assumed to have the name. Clinical diagnostic characteristics of RCDP include severe rhizomelia, that is shortening of the proximal segments of the limbs. Most children have bilateral cataracts present at birth. There is poor linear growth. There are developmental and motor delays. There are congenital contractures or decreased range of motion in the joints, as well as typical facial characteristics, which include a flattened midface and a depressed nasal bridge with anteverted nares. Here you can see a classic set of images on an infant with RCDP. You can see here the chondrodysplasia punctata itself, which has this sprinkled sort of salt and pepper appearance. You can see it here at the elbow, here at the shoulder, and in line. If you look at the arm, you can appreciate that this humerus is much shorter than the forearm and the hand, thus leading to the description of shortening and rhizomelic chondrodysplasia. At the spine, there is this characteristic clefting that occurs in the anterior vertebral base. The clinical presentation of RCDP was really first well described in 2003 by Dr. Pauly and his group at the University of Wisconsin. they described was decreased survival. They discussed that these infants feed and grow more slowly. Their seizures and the cataracts are present, again, most commonly at birth. And of course, the skeletal frequency of respiratory infections. And some of them had congenital. 20-something years later, that RCDP is in fact a disorder. Collagens are significantly deficient in the body. Up here. What is a plasmalogen? Well, this is a three-dimensional rendering of a plasmalogen. Plasmalogens are a very unique and important class, which gives them the difference from other phospholipids is the combination of a fatty alcohol attached to the backbone at this SN1 position with a vinyl ether bond in combination with polyunsaturated fatty acids bound at the SN2 position. Plasmalogens are made in the peroxisome, and here you can see a microscopic image of peroxisomes inside a cell stained red. We know that patients with plasmalogen have what we call classic RCDP, which does appear to be the most common type. Plasmalogen levels are termed non-classic RCDP. So we now understand that RCDP is a disorder of plasmalogen deficiency, and that deficiency can occur. All 5 of these subtypes are inherited in an autosomal recessive manner. Type 1 and type 5 are peroxisomal biogenesis disorders, whereas types 2, 3, and 4 are single enzyme deficiencies. Here you can see an individual peroxisome that is blown up, and within the peroxisome we have the GPS enzymes. These lead to type 2 and type 3 RCDP when these enzymes are not correctly and therefore not be able to create plasmalogens. PEX7 and PEX5, that is RCDP type 1 and type 5, are disorders of transport. They are biogenesis disorders. Functioning of these 2 proteins, this AGPS enzyme cannot in fact enter the peroxisome and is deficient. Lastly, we have type 4, which is an enzyme that generates a fatty alcohol from a fatty acid that then becomes incorporated plasmalogen molecules. So several ways, either transport or enzyme deficiencies, all have the same common and decreased plasmalogen levels, with the most common of these being the PEX7. So what are the current standards of care? Well, where plasmalogen, their deficiency affects the body. And we can see in this cartoon that this is really pretty global. Plasmalogens are a major lipid component of myelin, which is important in our nerves and in nerve transmission. So this is important all throughout the brain, both in development and in function of the brain. this is why we believe seizures occur. The cataract formation occurs in the eye, as we mentioned. Plasmalogens are an important component of lung surfactant in the lung. Obviously, plasmalogens can be in the heart and heart disease. It can be in the GI tract, specifically probably in the nerves that control the GI tract. We know that there are problems in the nerve conduction studies in long legs, and obviously in the skeleton as well. So plasmalogens are pretty ubiquitous, and therefore are throughout the. At this moment in time, care really is exclusively symptomatic. That is to say, if you have cataracts, there are standard procedures for how cataracts are treated. If you have congenital heart disease, we need to use the traditional methods, which are heart surgery. Seizures are also treated. Skeletal dysplasia, we pointed out the dysplasia in the x-rays before, but now we recognize that there are very specific and critical issues that can occur in, as well as feeding difficulties. We now have growth charts for RCDP, which can be very useful in determining and assuring that children with their slower growth velocities are in fact growing appropriately for their condition. And of course, we have the respiratory insufficiency we deal with the tools that we have. We have no way at this moment of going in and changing the underlying base of the condition. And really, those are, well, at its most extreme form, a major issue is mortality. Children have a lower Kaplan-Meier curve, which demonstrates that in two cohorts, both in the US and the Netherlands, at 1 year, there was a 93% survival rate. But if by the time these children got to be 5 years of age, this number had decreased to 2/3. We did not see any differences between the US and the Dutch cohort, nor are any differences observed between boys and girls. There are, however, suggesting that plasmalogen levels, when higher, albeit low, create a for the different types, where RCDP1 and RCDP2 are overlapping and similar. So what can we do to move from? This leads us really to what are the opportunities for progress? Well, as we think about clinical trials, one thing that is absolutely critical is for us to think about what are endpoints, what can we measure at the beginning and after an intervention, etc. So we need more natural history data. Natural history data can be prospective, that is going forward, or retrospective and looking back and using. We need to use this data and assess endpoints. These endpoints could be a quality of life instrument. Quality of life instruments really are best when validated for the, and the RCDP community is working on a validated quality of life tool specifically for RCDP. Biomarkers are very important. A simple biomarker could levels. We do think they correlate with disease. Clinical endpoints. Clinical endpoints. So that means how many hospitalizations did somebody have? How well are their use as endpoints? And really, this is the work of the entire group of people coming together here. It's the community, it's industry, as well as the FDA and other regulatory agencies to agree on what endpoints are clinically meaningful and what can and should be measured in a trial. Practical needs for RCDP, I think we need better coordination and better multidisciplinary care as our children are spread out across the country. For rare disease care, we can always improve our supportive management while we are trying to find disease-modifying treatments. And we need for targeted motor and cognitive disease-modifying therapies. Broadly speaking, they can be divided into 3 classes: protein or enzyme replacement therapies, and these would be effective. And lastly, there would be metabolic replacement, which is a direct replacement of the plasmalogens which these patients are lacking. So with their time and attention, we'll move on with the rest of the program.
We certainly all thank Dr. Bober for his comments and insight. And I have to say, I must also applaud all the parents there and caregivers for all you have to do in terms of absorbing all these science and patient care details. As an RCDP parent, it's almost like having a medical doctor and nursing honorary. Certainly respect of all this information and the complexities present for anyone. We're now going to turn to the core of today's session, which is to hear from the parents and the caregivers living. So I'd like to invite the panel 1 panelists to take their seats at the front. And if they can move forward as we're doing that, before we hear from them as participants, allow me to provide some context and expectations for this process in just a moment while I give you a chance to get settled up there. Introductory comments, which will help us not only for this panel, but for the second as well. As we've heard, patient-focused drug development is a more systematic way to gather patient perspectives and input on their conditions and on available treatments. So your input today can help inform the FDA's understanding of RCDP and the burden it presents to those affected and their families. Your words and your stories will inform drug development and review directly. This is a truly unique and important opportunity for the community. So today's session is interactive. You'll have different ways to participate. In our first panel, we'll be exploring the experience of living with RCDP and its impact on your child's daily life. In the second session, which is after the lunch break, we'll explore the various approaches to treatments, including preferences about future treatments. Panelists first, living with RCDP. These panels will help set a good foundation for a broader discussion by representing a range of experiences, RCDP, both in terms of the conditions, to share their insights. And after the panels, we'll be broadening our input in today's discussion for session survey, and will help inform the data for our patient report. As you vote, please only get one polling response per person with RCDP. If, for example, 2 parents are here on behalf of 1 child with RCDP, for the stage of experience of everyone living with RCDP. So following the panel remarks and the polling questions, we will move to a facilitated discussion with other members of our audience who are caring for someone with RCDP. During those discussion sessions, I will invite other members of our audience to participate. Your comments should focus on points that didn't come up in the panels or all you mentioned. We will have roving microphones. So I'll ask you to raise your hand when you want to speak, then identify yourself so that future listeners know you. And also to be succinct, so targeting reminders before we start with the polling questions. We're here to can identify with and hear those perspectives of those living with RCDP. That in, we ask in your comments so that we can hear as many voices as possible. And please know that if I ask you to wrap up a comment, it's only because we want to have time for
some connectivity issues, but we'll keep forward. So as Tim mentioned, this is a session where we really want to focus on the patient story. So again, keep our focus on that. I'm going to get us started with a couple of the polling questions. These are just polling questions to test out the system and then ask a few demographic questions. If we're able to get that on the screen, I think we're going to take a little break, I think, just so we can get everything connected again. In the meantime, I did want to make a point and say we do have some refreshments and drinks here in the corner. That'd be great. And once again, thanks again for your patience.
Ah, we're relaunching. Excellent. Oh, sure. Yes, but Sanjot, for our link, I don't have anything. So I'm not able to see the room. Okay, thank you. Ah, there we come. Very good. Wonderful. Well, thank you all for your patience as we sorted out the gremlins there. Ah, very interesting. So as we see people, oh, I was going to comment that we were all on one end of the spectrum, but so it's good to see our form. Folks need an opportunity to react to the QR code or so forth. Lovely. So as you see, there's a range of results and it responds very rapidly. We always give it a few seconds to be able to function accordingly. So are we good there?
Yes, we are.
Lovely. Why don't we go to our first actual polling question then? Polling question 2, if we can move to that. Which best describes you as a current caregiver of a person with RCDP or a former caregiver? So these are demographic questions similar to what you may have seen in the survey. Very good. So most folks are very actively, is always helpful. The historical grounding is very key as we learn more. All right, very good. Can we move to next question, which is polling question 3? There's no surprise that RCDP1 is being a more progressive and aggressive form. So next we'll move to our final poll. 7 months, 1 to 4 years or older. And just as frame of reference, a dozen at least. So important in other rare disease groups with whom.
Hi, my name is Brian Davidson, and I was Reese's father. Reese was born with RCDP type 1, which was confirmed by genetic testing. We did not learn of her diagnosis until after her birth. Her pediatrician noticed that she had shortened upper limbs and cataracts present at birth and requested that she be a bottle, and then we were not able to return home until an NG tube was placed. Before we left the hospital, we had to learn how to, and we found it difficult to balance her feedings through therapy to keep and improve the range of motion with her joints and her muscles. We were able to do things like most families with newborns, but we had to schedule and plan what we needed in order to stick with her feeding schedule, or we had to pack all the equipment necessary to administer her feed, which later on included a Joey pump. We worked with a GI doctor nutritionist regularly to update her formula for feeds when she appeared she was not getting enough calories. Around the third year, trips running became more difficult. She did running levels at night. A sleep study was conducted, and we learned she needed a little oxygen while she slept at night. After a few hospitals, Rhizomelic slowly took over as our main health.
Sharing your journey, your family journey with. We thank Casey very much. Example of how life is by the experiences you all have had. So thank you to her. And our next speaker is Betsy.
So we're actually, we're going to take a brief pause just as it looks like we lost our live stream. And once we get that sorted, we'll move on to the next speaker. Betsy.
Sorry, Sanjot. Then.
Yes, we're just quickly getting back onto the live stream. Our oh.
We're back.
All right, it looks like we're back online. Thank you for. We're going. So I'll introduce Betsy Grant.
Hello, my name is Betsy Grant, and I live in Washington near Seattle. My husband Steve and I are the proud parents of 2 sets of twins. Yes, 2 sets of twins. That's not the only thing that makes our family unusual. Our oldest son by 2 minutes, Caden, is currently 17 and has RCDP type 1. He has an atypical or non-classic presentation, so he is rare among the rare. His presentation is often referred to as mild. I've always found that description ironic. It is true that he is mild when presentation, but looking at how he is able to live his life in relation to his siblings or peers, no one would use the word mild. Bless him. Every part of his life starts with I don't know because we can't compare him to others. His growth, for example, is too small for the standard charts and too big for the RCDP charts. Each day, we move into an uncharted territory. As his family, our philosophy is take it as it comes, potential, and pivot frequently. RCDP affects every aspect of Caden's life, his physical and intellectual development, his ability to participate within the world around him, and the plan for his future. Physically, there was no obvious sign of RCDP at birth. He was born at 37 weeks and within the average measurements for a twin. Around 3 months, we noticed he wasn't looking at us. At 6 months, he was diagnosed with bilateral cataracts and had 2 corrective surgeries. He has worn bifocal glasses ever since. The cataracts led to blood tests that showed high phytanic acid levels, and that led to specialized genetic testing. At about 14 months old, we were given the RCDP diagnosis, but he showed very few of the typical markers. This was the first way that I was told my son would die. They told us he had a 50% chance of dying by 2 and a 75% chance of dying by 5, but they couldn't tell me what would cause him to die. From there, he moved along the physical milestones, but very slowly and with interventions. He was able to walk independently at 4.5 years old. He was a glorious menace. At around 5.5, the seizures started, and they have been the bane of his existence ever since. They started very small and have increased over time. He has 4 different types of seizures, plus what they refer to as erratic brain activity. His seizure treatments are a whole other story, but none of it has worked to control them. Around 10, I was told he was at high risk of sudden unexpected death from epilepsy, or SUDEP. And this was the second way that I was told my son would die. Currently, he has nearly constant seizure activity and anywhere from 2 to 10 tonic seizures every day, averaging about 30 seconds in length. Every time he has a seizure, especially in the middle of the night, I fear that that is the one that will kill him. At 11.5, Caden was diagnosed with T-cell lymphoblastic lymphoma. This is the third way I was told my son would die. We didn't know if his cancer is, we don't know if his son is, we don't know if his cancer is related to RCDP. He is the only known RhizoKid with that diagnosis. Thankfully, he hit 5 years in remission in February of this year, and so far he has no known lingering effects of the cancer or its treatment. The long cancer recovery, combined with the seizures and some orthopedic issues, have taken away his ability to walk independently. We are working on getting that skill back. Throughout his life, he has regularly received many therapies: vision, physical, occupational, and speech therapies. In safe spaces, he moves on his own, such as climbing on and off chairs and walks on his knees, but he primarily uses a wheelchair. Intellectually, RCDP steals his ability to learn beyond an extremely slow progression. At 17, he has many useful skills, but he is unable to do anything independently. He is unable to use a toilet, unable to dress himself, and doesn't understand safety risks, such as not touching hot surfaces. He is able to eat orally and can feed himself using his hands, but is unable to load a fork or a spoon. He is nonverbal and communicates his needs and desires using facial expressions and gestures, but is unable to answer even a yes or no question. Caden is curious and wants to participate in the world. His version of RCDP puts him in a limbo of seeing possibilities, allowing him some participation, and then hobbling his ability to thrive. He is a proud member of his high school band drumline and plays the maracas. He enjoys being a part of that community and wants so much more than RCDP will allow. He has learned to follow a tempo, but is unable to find a consistent beat or follow written music. He can move with the marching band, but is limited to where he can be pushed in his wheelchair. He is part of the group, but also far apart from it. Caden will soon enter adulthood. His occupation as a teacher is already set. With his tenacity, curiosity, and perseverance, Caden teaches everyone how to be a better human being and to not let obstacles, big or small, get in the way. RCDP creates a very murky path for him. His father and I must plan for his life to end early, but we also must plan for his life, which requires constant one-to-one assistance to extend far beyond ours. Many of his skills are diminishing as the seizures and RCDP slowly chip away at his light. We seek opportunities to continue to learn and participate, or we seek opportunities for him to continue to learn and participate in his world where few or perhaps no opportunities exist for him. And we hope for new interventions that will improve his ability to thrive. Thank you for your time.
Thank you very much, Betsy. Our next speaker is Mindy Lee.
Hello, my name is Mindy Lee. I'm the mother of Jake and Jordan Cerner. Doug Lee is my husband. Jake is 22 and Jordan is 18. We live in North Royalton, Ohio. Both Jake and Jordan have RCDP type 2. which is a debilitating genetic disorder. Jake was diagnosed at 6 months after I was told he was failure to thrive. Jordan was diagnosed during pregnancy. Both cannot run and play like typical children. They have limited mobility and cognitive functions. Their disorder requires us, along with nurses and aides. Jordan also requires a night nurse 2 times a week. They both enjoy music stimulation as well as visual stimulation. As a result, OT, speech, and music therapists come in their home. At one time, Jake participated in outdoor activities like walks and miracle baseball and going into the pool. But because of his sensitivity to heat and sun now as he's gotten older, he can no longer do that. They both have respiratory issues that require the use of a nebulizer treatment and vest treatments. This prevents congestion settling in their lungs as they have gotten the frequency of these treatments have increased. They also have excessive secretions, which require secretion, reducing medications, and frequent suctioning throughout the day. They have pulse ox monitoring at night. Jordan has a CPAP and oxygen as she has developed sleep apnea. When they were younger, they developed cataracts, which were removed. Contacts were initially used, but years later, inocular lenses were placed, and they are still in use today. At a very young age, both started having seizures, which require medications on a daily basis to limit and control the seizures. They're on about 3 right now. They are not seizure-free, but the episodes are less frequent and about 10 or less per day and less severe. Limbs, joint stiffness, and limited mobility. Over time, their legs and muscles have gotten tighter. They can no longer use a gait trainer or sander that they once really enjoyed using. Jordan currently has issues with her hips, one of which is displaced due to a shallow socket. This requires a steroid and Botox injections every 3 months to alleviate the pain. Both have had multiple surgeries on their shoulders to relieve the tightness and increase mobility. This was not a permanent solution as the tightness has returned. Jake and Jordan both have gastric issues as well. When they were both babies, they drank from a bottle, but started aspirating while doing so. Jake now has a G tube at one point. Jake was able to take nutrition orally, but that is no longer the case. All the nutrition is given via the G tube bolus throughout the day and a pump fed overnight for extra calories. Jordan has had G-tube and could be fed via bolus and overnight feed pump as well, but since she has changed to a GJ. Thank you. Tube fed, which is fed through the whole day and night. She also has had a gastric stimulator for her gastroparesis symptoms, but this has also been removed. Jordan has a Nissen to prevent reflux. They both take anti-nausea medications to help prevent reflux. They are given it 3 times a day. Even though they both have had ear tubes, Jake has developed a severe hole in his ear that requires corrective surgery coming up soon. Jordan has a heart condition as well that requires daily medication to control it. Since they are developmentally delayed and they are incontinent and require to wear briefs full time. Over time, Jordan's gastric issues and scoliosis made it difficult for her to go on her own, so laxatives and massaging her abdomen to get her to go helps this condition. Both Jake and Jordan see a total of 10 different doctors to control the symptoms they are dealing with. This dream team is led by a comprehensive doctor that helps keep things under control and consistent. Their best days are when they tolerate all their treatments and therapies without issues and have a peaceful, uneventful day. These are rare. The worst days are when they are sick, running fevers, more frequent seizures, and not tolerating feed and treatments. Since they are immune compromised, they are susceptible to getting ill very easily. A simple cold could land them in the PICU. They need for treatment through the day. that makes it challenging to do any activities outside of the home. When we do go on trips, we are required to take the breathing, therapy devices, feeding pumps, all their scheduled medicine and syringes. Hormones make it bigger. As they get bigger, the limbs are getting stiffer, which greatly reduces their mobility and causes them a lot of pain. Function continues to worsen over time as they get older, and they are challenging to transport and lift. I would like to thank you for your time today and giving our children hope.
Thank you so much, Mindy. So it looks like we're having another internet pause. So we're just going to take a quick break again. Once again, feel free to take any refreshments over on the left side of the room. And as soon as we're back up and running, we'll get started. All right.
Story during our preparation, so I will capitalize on that. And are we ready? Thank you, Mindy. Sorry about the IT complications.
Yes, Tim,
You're
we're
still-
ready.
Jake. Thank you. And our next and final speaker for this panel is Hannah Peters. Thank you, Hannah.
Hello, my name is Hannah. My husband's name is Sully, and our son Jude Peters has classic RCDP type 1. He was diagnosed in infancy. During utero, we were told that they didn't know if he would be compatible with life outside the womb, and they told us that we wouldn't hear him cry because he would need immediate assistance breathing. We knew he had a severe form of skeletal dysplasia, but we didn't have an official diagnosis. When Jude arrived, he let out a vigorous warrior cry, and since the beginning of his life, we have referred to him as our brave little warrior. Jude was clinically diagnosed with RCDP at 2 days old and was officially diagnosed through genetic testing when he was just a few months old. When Jude was initially diagnosed with RCDP, I don't think we realized in the beginning how many additional diagnoses would fall under the underlying diagnosis of Rhizomelic Chondrodysplasia Punctata. We hardly had time to wrap our heads around the realities of the initial diagnosis before the others started to present. Jude experienced his first seizure at 2 years old. This actually took place at our very first RhizoKids conference. Shortly after, he was officially diagnosed with epilepsy. While we have found ways to mediate his symptoms, sometimes that threshold can lower, causing breakthrough seizures that takes effect on his overall health. I think one of the hardest things about Jude's seizures is that sometimes him getting too excited can overstimulate him and cause him to seize, and it breaks our hearts every time. Shortly after Jude was born, he began therapies for occupational, physical, and speech therapy. It used to require a quiet room and tears from both him and I to simply change a diaper or his clothes because his joints were so contracted. Therapy has helped so much, and his pain and contractions have greatly improved over time. Jude used to love speech therapy and eating by mouth. He really loved his bottle and baby food. He fully lost his ability to eat by mouth after aspirations became frequent, leading to pneumonia. Jude gets 100% of his nutrition and medication through his feeding tube now. While therapies have improved his life, there are still many challenges, including spinal kyphosis, stenosis, and a tethered spinal cord. We try to be diligent in keeping him moving in therapy to continue to reach milestones and to keep him more comfortable while also trying not to wear him out. It's a delicate balance with a kid so complex. I would say epilepsy, respiratory disease, and kidney stones have had the most negative impacts on Jude's daily life. I remember in the beginning being so heartbroken over the fact that I was hearing he'd never walk and talk. And while those realities still carry a sting, and I would give anything for him to have the ability to wrap his arms around my neck or to verbally tell me, "Mommy, I love you," the realities of respiratory illness, neurological distress, and pain have taken a front row seat. We are unable to attend a lot of family activities and family functions during cold and flu season due to the fact that a common cold can put Jude in the ICU. There's no such thing as a mild respiratory virus for Jude, and it becomes very serious every time. Taking him out during that time is always a risk, yet we strive to give him the normalcy of family time as safely as possible, but it's never easy. Jude loves nothing more than to be surrounded by family. He has many cousins that adore him. Jude has a lot of great days where things are smooth sailing considering this condition. Overall, Jude is a joyful little boy in spite of his many challenges. However, all of that can change very quickly, meaning we have to stay vigilant at all times and stay on high alert as to when it's time to increase Jude's level of care. Kidney stones have been a battle he's faced for over a year, requiring 4 surgeries, countless days in the hospital, and unbearable pain with great distress. We're still trying to find ways to manage kidney stones and the many effects they have on him. Over time, his symptoms have changed, requiring 24/7 oxygen dependency and frequent airway clearance. He used to only require it at night. His medications list and required equipment continue to grow, as well as his specialists, both locally and out of state. Our biggest concerns and worries are his ability to recover from illness, the long-term effects that epilepsy and respiratory disease and pain management take on him. We celebrated Jude turning 10 in April, his decade of miracles. After 10 years of being RCDP parents and full-time caregivers for Jude, we have learned so much, but it continues to be a learning process every day. It's our greatest honor, and he is our world. We are excited for the possibility of a new drug that can help manage Jude's overall health and in turn increase his quality of life. Jude is nonverbal, yet his life speaks volumes. He has truly taught us that both grief and joy can coexist. We've seen him face massive battles and come out smiling. And while he can't speak verbally, he tells us how loved we are by him in his very own special and beautiful ways. Because of our joyful Jude and his incredible strength, that is a pillar for us. We remain hopeful, joyful, and we fight daily to be as strong as Jude and his amazing Rhizo brothers and sisters. Both are angels and warriors. On behalf of Jude's family, we'd like to thank MedLife Discoveries, Nemours, and RhizoKids International for all of their hard work and dedication in finding a treatment for our Rhizo warriors. Getting connected with RhizoKids International was life-changing. They reached out with so much knowledge, support, and hope. We are beyond grateful for this team and family. Together, we are strong, and truly, hope is everything.
Thank you, Hannah. So it looks like we're going to get connected back to Tim. Looks like the rain might be fighting with us today. So I want to thank you all so much for sharing your stories. I know that it was difficult to share, but we appreciate it. As soon as we get connected, we'll move into our next portion of the session, which is another round of polling questions. Questions will be related to symptoms of RCDP as well as impacts. And then we will move into our discussion where we'd love to hear from audience members as well to make it more interactive. So just a note to folks who are able to hear us through the YouTube live stream, we're still troubleshooting some internet connection issues and we'll be online as soon as possible. Hi, once again for folks on the YouTube, we're still trying to connect. We're going to try to get some folks on the polls soon, but we're still trying to connect the main presentation and Tim to the room. So if you could bear with us.
USB-C because I had to put it on the Wi-Fi. Oh, okay. There was no power in my office. This allows you for Apple.
Oh, I have one.
Oh, I think I have one. Oh, I have one. I have one. Yeah. Oh. We're good. Thank you. Okay, we're gonna try and get Tim back in. Let me just see.
All right, we are attempting to connect and we'll try to get Tim back in to the Zoom.
I don't see. I'm not using this Wi-Fi, so everybody can try. Whether it works or not, I don't know the answer.
Sorry.
Okay, now how many things get the polling?
All right, so first and foremost, Tim, are you able to hear us?
I can hear you now.
Yay, great, great. All right, next up, let's see if folks are able to get connected to the polling website on the screen.
Great. So we're not on RCDP, but mother.
Some rain over here. All right, so we have a few folks that are connected. I think you should still be able to get onto the Wi-Fi if it starts working. So we're on a separate Wi-Fi now. All right.
Well, thanks to all the speakers for sharing and the time he took in preparation with us as well. So it's appreciated. And we do want you all to know that final reports will be edited, so you will not see gaps in there.
I think we can move to the first question now. So Tim, are you able to see the question?
I am. Thank you very much.
Great.
So just giving it a moment to allow everyone to vote, but seems like other than one leading candidate there in terms of the visible appearance of the humerus and thigh bones, that there's certainly a variety of effects showing the, the breadth of initial manifestations that can be recognized. And that's also reflected in what we heard from our panel members, that there may have been different presentations, different orders of severity. I captured some of the points that each of you raised, and fortunately did that and shared in our preparatory, and came away with a number of really important terms that I think we'll want to reemphasize as discussion comes up. But variety is the spice here. So with that in mind, any other comments before we move to the next polling question, number 6?
No comment.
All right, hearing none, let us proceed to that. And we will capture these results, of course, and it is fairly similar to what we saw in the pre-survey. So this question is about how much time elapsed between your child's signs and symptoms of RCD. 0 to 3, 4 to 6, 7 to 11, or 1 to 2 years or beyond. But definitely 90% above 6 months or less, and the vast majority of that, 3/4 of the voting, reflecting that it's very, very early diagnosis, which, as new therapies become available, will become a very important point. Early interventions in other rare disorders tend to be some of the most effective. It's more challenging, obviously, when conditions have developed where some parts may be reversible, others less so. So that's very helpful to know. And I think we've heard from several of the speakers about some of the potential reasons for delay. Of course, being a less severe form, if it's non-classic, and so forth. All right, I think that's been helpful. Shall we go to polling question 7, which for those of you who are polled out will be the last one we do before we have open discussion. And this question says, which one symptom of RCDP has had the greatest impact on the life of the person for whom you care or cared for? I'll give you a moment to vote. But for those who come up with other, it will be helpful to hear comments on what was the most impactful. And just guessing, perhaps things like respiratory complications, cardiac, and so forth, as were hinted in the pre-survey, are likely to be important other category. So that's one of the things we're going to come to as we move forward. So certainly mobility and comprehension things make for tough day-to-day interactions. And thank goodness, when I trained in cataract surgery was not so efficient and effective back then, last century, as now. So thankful for that. All right, thank you everyone for responding to those polling questions. So now I'm going to show the questions that we're going to try to springboard from your voting here to what we'd like to talk about a little bit further. So let us move to the questions that we're going to discuss based on some of these. And if we can thank you for the next slide. Let me read each that same roadmap. And so questions, number one, which aspects of your child's RCDP symptoms have the most significant impact on their life? Second, or able to do so because of their symptoms. Third, how does your child's RCDP symptoms affect their daily life on best versus worst days? And that's also, I think, important in every family setting, their life's bookends, if you will. So we'll definitely focus on that in a moment. Fourth, how have your child's symptoms changed over time? Fifth, would you define your child's RCDP symptoms as being well managed? If not, what is the most challenging to handle? And I realize some of these and how we may discuss them. And then sixth and finally, what worries you most about your child's symptoms? So let's back up to question one, which aspects, and I presume those of you who responded other than what were the listed things in polling question 7, you may wish to share with the group. Several folks who are monitoring those responses for you.
At this time, if anyone from the audience would like to provide any comments or discussion, we would invite you to come actually up to the top if you're able to. Yes, right here would be great if you could.
No, any discussion there? We want to be sure everyone.
Sorry, is this a good place to stand? So I guess my comment is on the other that we were talking about earlier. Elias is mine and John's son. His main thing that impacted our life, he had cervical stenosis. So it was pretty severe in his like C1 to C6 or C7 vertebrae. He's had surgery, so that's no longer his main thing. His main thing is now cataracts. But with the cervical stenosis, we just weren't sure how life impacting that could be. Like, it wasn't urgent when he had surgery, but it could become urgent and deadly had we not had the surgery. So that was our number one impact. I don't really have much more to say other than that.
Thank you for those comments.
That's very helpful. And there's no such thing as minor surgery when it involves your family, children or otherwise. So thank you for that. And let me add a few things that I captured from several of your comments. There's no such thing as a respiratory disease that's mild in RCDP children. That's certainly something that would be an experiential thing. As they age, the stage of severity and complexity becomes greater. So there may be things that become more significant over time. Let's see here. Interesting that there was something we played off of from the pre-discussions about appreciating that there are internal and external threats. External being things like exposed to other respiratory illnesses or folks that they come across, family members or so forth, and internally from aspiration or things of that sort. So it's important to address those things. And significant impact on life. There were things about grief and joy roller coaster, which I thought was very interesting and reflective of the challenges of every day being significant impact of positive or negative varieties. Other comments from those of you online? Want to be sure everyone has an opportunity to speak so that they can share accordingly.
While we're waiting for those, Tim, we do have another comment here in the room.
Please.
My name is Ashley Nathan. His poor motor skills greatly impact his life, hinders motor skills development. The limitations in his movements, simple actions like scratching his nose, a challenge. He cannot do that. Additionally, his forearms impede his progress in learning. His forearms, I'm sorry.
Thank you. We did get a comment from online via Melinda that the greatest impact for their family is respiratory and seizures, especially when they may occur together with Ethan. So that's certainly a challenge, and it goes to the aspiration point that is so significant for many. One other thing I captured from the panelist comments, and this may have been from you, Brian, but it was as these children age, you're burdened with more machinery to move around and less ability to be able to gather with family. And with aging comes more complexity and more complications from many of your comments. So from many comments from all of the panelists. So that's particularly helpful. And other online or in-person commentary?
Yes, we have a few more in the room. Just hold tight.
Please.
I'm Sue. I was Liliana Oxsmith's caregiver from age 2 until she passed at age 6. Taking care of her was, we're kind of in the same boat that Casey's in that we chase malacia, and it's a respiratory problem that the airway just, falls and restricts breathing possibilities. And so when we opted to do a tracheostomy, and that brought about all kinds of equipment for us and really a huge inability to even really go anywhere. We had an ICU unit in our home, and we had nurses when we could get them. Otherwise, I took care of her. But I think the biggest thing for me in that arena was that the length of time it took to get the equipment, like trachs, they had to be specially made because our kids have what they refer to as treacherous airways and it took 5 weeks just to get a trach made. And she had to wait in the hospital. I mean, she spent a significant amount of time in the hospital. So that was our biggest thing, was respiratory.
Great, thank you so much. Tim, I believe we have a comment.
Great. I saw one comment back from Hannah that McKenna's greatest challenges relate to seizures and spinal. So I guess we're getting into the best and worst days, and it would be the kind of roller coaster of grief and joy that you experience.
Are there any other comments in the room? Anyone would like to share?
All right. Hi, I'm Jenna. This is Madeline. I will share what turns into the greatest joy throughout the year or throughout the time with Madeline. In addition just to her every day and her every smile. But it is after an illness, because when she gets sick, she stops smiling. And I know she's feeling better when I see that first smile. And that can take days or it could take weeks. And during that time, when it does take weeks, you stop and you think, when was the last time that I saw her smile? And was that going to be the last time? So when you see it, you know everything's going to be okay for that moment. So thank you.
Thank you so much for sharing that. All right. Tim, we have one
Oops,
more.
sorry, I was
Oh,
on mute.
no worries. Tim, we have in the room, so I'll pass the mic.
I'm Nathan's mom again. I'm sorry I froze. But I wanted to say, like Hannah, one of the most significant things that happened to us is when Nathan was diagnosed with epilepsy. And like with him, they diagnosed him and they told us that every seizure that he has, especially in the middle of the night, that could be the end of him. And it was so scary. And we worry every day that something could happen. And living like that, it's really hard. It really is. But we find joy in him every day as well. He smiles, he laughs, he'll tell us, Mama, I love you, and Dad, I love you. Those are great things. Those are things that we hold on to every single day.
Thank you so much.
Yeah, let me say thank you as well, and also take the opportunity to remind us that we appreciate how challenging this is to have to share. It helps to put together this voice of the patient report, which then helps in shaping things like what are acceptable endpoints in clinical trials? How does one inform what to collect in terms of clinical trial information so that what results in drug development later for this community will serve as a springboard, if you will, to the kind of considerations that drug developers, that FDA, that others may find helpful to their pursuits. This is really valuable.
Are there any other comments in the room? All
Or
right.
anything online? I'm trying to keep up with. I was capturing several other things. One of the comments, and I think Betsy, you made this, related to uncharted territory. That's something that probably many feel as ages and stages evolve, and the range of activities of daily living change over time. You get involved with more medical care practitioners over time. You get more machines and complexity over time. So it's things across your familial experiences. It's probably very helpful in shaping expectations for others so that there's less uncharted territory. Other thoughts or comments? Recognizing that we stand between you and a soon-to-be lunch break, and I'm sure any of you can use that nutrition plus a break for other purposes as you need it. So anyone care to volunteer more about the notions of best days and worst days and how we might creatively deal with especially some of those challenging days?
Yep, we have a comment here.
Hi, this is Betsy again, Caden's mom. Just wanted to share. So our best days and worst days, because Caden is so different from many of the other kids, are a little different. I was just sharing that I'm actually able to get hugs from Caden, which I of course appreciate very much, and that makes any day the best day when you're able to get a hug from any child, but especially one that struggles as much as kids do. But the worst days are the days that you anticipate, or at least for me, we anticipate him being able to do something, participate in a band concert, and we get there and he's having a great day. He's actually having a great day today. And you allow yourself hope to be able to say, oh, he's going to be able to do this and he's going to be able to participate. And then 2 minutes before a band concert starts, he has a huge seizure and then he sleeps through the whole thing because his body is wiped out from it. Or in the middle of on stage, he has a seizure and interrupts the concert. So it's just things that you have little bits of life that you are like, oh, they can participate, they can do this. And then RCDP just comes in and rips it away from your heart and rips it away from the kid. And that is heartbreaking over and over again. So you can have your best day and your worst day all in about 5 minutes.
Oh dear.
Thank you.
Yeah, I really do appreciate that.
We have one
And,
more comment here, Tim. Oh, apologies if you want to. Do you have any comments, Tim, before we move on to another comment in the room?
Yes, please go ahead. We have a couple from online as well.
Okay. great.
And you can talk about any topic you wish. We want to hear from everyone possible.
Hi, it's Jude's mom again, Hannah. After Betsy talked, it got me thinking about, our best and our worst day and how quickly that can change. And Jude actually has been dealing with kidney stones. And when you have a kid like Jude with epilepsy and respiratory complications, when something like that happens, it honestly hits all systems. So when he's in like a high level of pain, he breathes harder. So, he only has so much reserve there. He breathes harder. And when he's having that much pain, he has more seizures. And then that affects his breathing. And so just being vulnerable, we were really nervous to come to conference because he's been dealing with stones and all these issues that come from that. And we spent all night up in the cabin because he was in like unbearable pain all night. And he's in the room right now, and I didn't think he'd make it in here today. But we had a great ride down, and he was doing wonderful and great. And he smiled at people. He danced with one of the twins that are here that love the kids, and they're involved volunteers here. And he's had a great time. But then in the snap of a finger, we're up all night with him. And then trying to get up in the morning because we wanted to be here. And it really is that fast that it can just change because of RCDP.
Thank you, Hannah.
I was going to add a couple comments from online that David passed along and captured. They're from Melinda and Casey, and both had commented on as their RCP children age, they become more fragile, and that then creates obviously new needs. Any last comments about how symptoms change over time or the worries that you may have?
We have a comment by Mindy.
Jordan's having older kids, it's a blessing, but also you would think it gets easier and it gets harder because as they get older, they get stiffer. Hormones kick in. Hormones are not fun for any of us, but for our kids, it gets a lot worse because with the RCDP, they can't regulate their body temperature. And right now, Jordan is going through a lot of issues where her face just turns bright, and we just have to try to cool her down before she starts having seizures. Jake has a lot of seizures too. He gets frustrated. We have good days and bad days. And we always say it's like taking 10 steps forward, and on the bad days, it's taking 20 steps back and almost falling off the cliff. We're blessed to have them. I pray every day, and I thank God for every second. Anybody who follows me, my motto is hope is everything, because without hope you have nothing, and you just got to keep being the voice for your kids until they have one. Jake does say, "Mom, whether he's mad at me or not, it's always ma, ma, ma. And he has gotten a little attitude on him as he's gotten older. He's 22. So, but I wouldn't change a thing except getting him a cure, helping him out, letting him, he's trapped inside there. I don't want to take up too much time, but all this time I've been saying that he's never going to learn his ABCs and 1, 2, 3s. We need music. We don't need a teacher. And we got an eye gaze board. And to my surprise, he does know his letters. He can pick out his letters on the eye gaze board. So he showed me.
Extremely well like we didn't come across our diagnosis. He was about 10 months old. We discovered cataracts like 7 months into his life. So it was a journey to get to our RCP diagnosis. So most of our difficult days were before. And then when we met all the specialists at Nemours, our days got significantly better. But I would say one of the things that I'm concerned about, I don't know, I know I've heard typically around 2 or 3 is when seizures develop and things like that. So one of my fears in the future is, experience. We're thankful to have a pretty active little boy. And some days are harder than others, but I think our most difficult day with all of possible symptoms are like, is he poorly this time? I've gotten lucky twice so far. So irregularities here and there, but nothing that's concerned the doctors yet. So
Thank you, Brittany.
Any other thoughts and comments that you'd like to share? And we appreciate every one of you bravely stepping out to be able to enrich the thoughts of others through your experience. So guessing there may be rumblings of hunger in various spots. Thank you all for sharing. And it's now time for the lunch break. If you haven't had a chance to comment yet, do not worry. You'll have another opportunity in the second half of our session. And that's when we'll come back to talk about treatment approaches and desired future treatments. So now we have planned an hour and 15-minute lunch break, and we'll return at 1 p.m. Central Time, unless I hear something else from folks there indicate that. And we would ask our panelists to come back 10 minutes before the start of the session so that you can get seated in front.
We'll be breaking for lunch if folks can come back at 1 p.m. for the afternoon session. We will see you then.
Very good. So thanks again, everyone, and enjoy your nutrition.
Welcome back, everyone. I think we're going to just take 1 minute to see if there are others who will come into the room. I hope you all had a good lunch. Yeah. I think if we just that much. Oh, yeah. I hope you all had a great lunch. Tim, off to you.
Thanks very much, Sandra, and welcome back all to the patient-focused drug development session for RCDP. This morning, we had a great series of presentations and discussion to help us and all those attending understand what it's like to live day to day and hour to hour with RCDP and how it impacts everyone's daily life who's involved. We're now moving to our second topic today, where we're going to talk about both current and future approaches to treatment. Very broadest of, so this means medicines, it also means medical devices, but we're also talking about a greater range of things such as physical therapy, occupation, or have previously done. In addition to hearing how well or maybe how not so well some of these interventions work, we also want to explore some of the most significant downsides of those different treatment approaches, or the burden of needing to undertake a certain treatment approach or regimen, what it does to otherwise daily routine. So anything that you would do as a downside, we want to hear about. The way drugs, they look at the expectations the community and patients have for benefits and also the risk tolerance. So understanding what those kind of balancing acts can be is really important. And we've explored this range of different current treatments that you have available and how well or not well they're. We'd like to see, everyone I'm sure would like to see a complete cure for RCDP, such as with gene therapy, as we heard about earlier, very briefly. Short of that, we want to know what specific things you'd look on as an incremental treatment advance that would be easing the everyday life strains. To help us kick off this discussion on current and future approaches to treatment, it's my pleasure to introduce members of our second panel of the day, Rebecca, Katie, Jenna, Teresa, and Melinda, several of whom will present. Rebecca?
My name is Becky Brown, and I am from Monroe, Wisconsin. We, my husband Jim and I, are the parents of Georgia Brown, and she's 36 years old. She had two siblings with RCDP, an older brother who lived to be 10 years. So we had the two of them together for 7 of those years. And another baby brother lived only 16 days. My husband, Jim, and I also have 3 adult children. Georgia has a very will to live. She had birth to 3 and then attended our public schools until she was 21 years. In our town, there are no appropriate adult day services or adult family homes that could take on Georgia's level of care. So she continues to live with us at home. We have caregivers about 3 days a week, and Jim and I are caring for her about 4 days a week. It's a very complicated situation, but we manage, and we have had some wonderful long-term caregivers. Our problem right now for Georgia, she is stable, but we are getting old. Under compassion care, it it'll be great. And she's been real stable, so we'll be able to see if there are some improvements, which is what we're hoping for. Some of the things we've tried in the past have been under about it a long time ago. He had this great idea that we should give her a shark oil supplement when she was a baby. So we gave shark oil supplement to Georgia and the older brother, Leighton. We were under the geneticist's care and we had MRIs, but after 3 years, they're pretty bad. And so we tried, about that time, the ketogenic diet became very popular and we tried it. We had to make a homemade ketogenic diet because they didn't have it as a canned formula. And it helped. The seizures stopped. It was great, but it made her lose weight. So she lost like half of her body weight. She got pneumonia. She had a failed swallow study. So we had to place the G tube for her feeding. And that there was a complication. She needed a second surgery of orally anymore. But things got smoothed out there. But she lost weight on it and it put her into liver failure. So she was critically ill there for a few years in her high school years or teen years. Her hair turned like malnutrition, her hair turned yellow and hospitalizations were 2 or 3 weeks at a time. The other kids were in high school. It was very disruptive. But she got better. We got her on a new canned formula of Peptamen Junior. We gave her extra vitamins and she improved dramatically. Her hair turned black again. She gained weight. Her sexual development continued and her final 2 teeth all came in a year. It was really dramatic that she got so better so fast. So she finished high school at age 21. She aged out of school and she stopped having OT and PT. Since that time, she's went 17 years without being in the hospital. That was pretty good, 17 years. And then at the age of 34, she had, so it's like her bowels were kind of getting sluggish and aging. And we upped our regimen on what would help her with her bowels. And now she's been on the new medication, the plasmogens, that it will help her brain and her central nervous system. If she had improved cognition, that will improve everything. It will improve her communication, her motor control, and it could also help things like the autonomic systems in the body, like your bowels and those kind of things. So we have great hope. She's been very stable, so I think we'll be able to see if there's improvements. We're going to see it right away or be able to observe it because she's been so stable. So here's where we're headed. We love Georgia's. We're committed to her best life. She has proved over and over again, she's not ready to give up on life. Just a few months ago, Jim and I got COVID and we shared it with Georgia and she shared it with her caregivers. She coughed nonstop for 2 weeks, coughed another week for the 3rd week, and then she gets better. That's what she is. She's very resilient. She suffers terribly with an illness and then gets better. So that was an emotional decision to make, but of course we haven't had to use it because she just keeps going along. So we're hopeful for this treatment. We're going to look for all the different things. We're hoping Jim and I can figure out continued care for her as we age and just have lots of hope for her future and hope that we continue to figure things out. So now I want to add a little something from our talk earlier this morning. One thing that we all need, our kids and ourselves and our family and our caregivers, is the quality of resilience. When you have a challenge like Georgia and her disorder that's so unusual and so severe, what she needs from us is resilience to keep going, to roll with the punches, to learn from our experiences. This conference is great because we can share and support one another. So I just hope you go home and you tell your families, I have a new word I'm going to live by the next 12 months. It's resilience. I'm going to be resilient with whatever life brings us. Thank you.
Thank you so much, Rebecca.
Thank you very much. And Our next speaker is Katie Green.
My name is Katie Green, and my husband Daniel and I live in Tulsa, Oklahoma with our 3 children. Andrew is 14, Owen is 10, and Charlotte is 5. Charlotte was diagnosed with RCDP type 1 at 2 months old. As with all children with RCDP, Charlotte has many challenges that make her daily life more difficult. Most notable are her daily seizures, difficulty in managing her secretions, inability to hold her head up and control her arm and leg movements, and joint pain and stiffness. Seizure management for Charlotte has been particularly challenging. She had her first seizure at 18 months old, which is when her neurologist put her on her first seizure medication. The medication we most recently tried for her gave her the most seizure control and reduced the amount of seizures she had from 20 to 30 down to 10 to 20. However, the negative side effects that she experiences due to this medication just outweigh the benefits that it's provided. It made her extremely sleepy so that she was only awake a few hours per day. Her personality just seems flat and her movements have significantly diminished while she's been on this medication. She went from being wiggly, happy, and interacting with our family to being lethargic, serious, and just sleeping most of the day. We are now working on weaning her off this medication and trying to start a different one to help manage her seizures. Daniel and I both work from home, and we spend a large part of our day caring for Charlotte, most of which involves respiratory care. Her inability to manage her daily secretions puts her at very high risk for aspiration, so we are very diligent with her daily respiratory care. We give her 2 nebulizer breathing treatments and 2 CPT vest treatments each day, along with frequently suctioning her nose and mouth throughout the day to help eliminate excess saliva and mucus. She also takes a medication to inhibit the production of secretions, which has helped quite a bit. The need for scheduled respiratory care frequently interrupts her naps and just gives her less time to play and interact with our family. We have to schedule each vest treatment at least 1 hour after she has eaten a meal, or she will likely vomit from the shaking. It's a very difficult balance between ensuring she gets all of her feedings in for the day and still has enough time to digest the food before each vest treatment. Her evening breathing and vest treatment often coincides with dinner time, which means that one parent has to do respiratory care with Charlotte while the other eats with our older kids, and then we switch off. It also makes traveling more difficult since we have to travel with lots of respiratory equipment. Charlotte's lack of head control and inability to purposefully move her arms and legs make it impossible for her to play independently. She relies completely on her dad, her brothers, and me to hold toys and turn them on and off for her to enjoy. She spends a lot of time watching children's shows on an iPad, which she likes, but would definitely benefit more from being able to hold and play with her own toys. Instead of taking dance lessons or going to soccer practice, we take her to weekly occupational therapy appointments to work on head and trunk control, reaching, and to help stretch out her tight muscles and joints to prevent contractures. She is unable to lift her arms above shoulder level, and her joints are often stiff and painful. We do a lot of massage and stretching at home, but occupational therapy helps the most. She also wears ankle-foot orthotics for several hours a day to prevent contractures in her ankles. Other than a cure, we are hopeful that a treatment for RCDP would help most with the neurological difficulties of RCDP, which affect Charlotte's daily life the most. We are hoping most to see a reduction in seizures, an increased ability to manage her daily secretions, and the ability to control her movements and just interact more with the world around her. Charlotte's physical health, mental health, and dignity are of the utmost importance to us. Before beginning any treatment, it is absolutely crucial for us to ensure that that treatment would be safe and that possible side effects would be minimal. We also want to make sure that any treatment would not be painful or distressing to her. We want to give her the absolute best quality of life possible, and we would give anything to improve any of the symptoms of the disease for her. Thank you.
Thanks very much to Katie and to Daniel, as well as to Charlotte. And our next speaker is Jenna Kirby.
Take a minute to breathe. Hi, everyone. Thank you for allowing me to have the honor of being the voice for my daughter today. And please join me as I take you behind the scenes of what living with RCDP is like in our family and the treatments necessary to maintain and improve a healthy quality of life. My name is Jenna Kirby, and my husband Ken and I live in Hilliard, Ohio, and have an almost 8-year-old daughter, Madeline, who has RCDP type 1, and a 10-year-old son, Trip, who does not. Madeline, or as we call her, Maddie, was initially diagnosed with RCDP through X-ray imaging that was completed while investigating fluid on her lungs shortly after birth. It was a few weeks later, while still in the NICU, that she received the official diagnosis with genomic testing through blood analysis. During her NICU stay, she received multidisciplinary included pulmonology, physical therapy, ophthalmology, orthopedic, and other specialties for diagnostic, research, and preventative care needs. You see, Maddie was our children's hospital's first with RCDP, and we were 100% reliant on the medical research at that time that was available online, along with the lived experiences of other RCDP families. Thankfully, the geneticist that we were working with was a former colleague of Dr. Nancy Braverman and was able to connect with her and help provide us with some more hope and information that was published and available. Over the next 8 years, Maddie's life has consisted of multiple hospitalizations due to respiratory illnesses, surgeries to remove cataracts and G-tube placement, diagnostic and preventative therapies, and she requires various assistive devices to aid her in her daily life. Her seizures and tremors are managed with daily medication, and on occasion, her seizures cause her to go hypoxic and require high-flow oxygen and multiple doses of rescue medication to pull her out of them, those of which have always resulted in hospitalization during the post-seizure recovery. Maddie is also reliant on daily stool softeners and probiotics to manage her gut and bowel health, as well as acid-reducing medications to manage her reflux. Without these medications, she would be miserable and suffer debilitating gastrointestinal issues. For Maddie, a good poop means it's going to be a good day. For the most part, Maddie's care is well managed by her father and I in conjunction with her medical team and her in-home and school nurses and aides. But I cannot stress enough at how exhausting it can be with the mental and the physical and the emotional load that is carried by her father and I. When she is well, she is thriving. But when she's sick, it can take her weeks to months to recover, depending on the severity. In the fall of 2022, when Maddie was only 6 years old, it was the first time that she did not qualify or get approval for the RSV vaccine. And it was during that time that she almost lost her life. She had contracted RSV along with pneumonia and the flu, and her body was in septic shock. The RSV vaccine, along with other preventative treatments, is so vital to reducing the impact that respiratory illnesses have on children with RCDP. With any treatment, medication, or vaccine for both therapeutic and preventative needs, we must always determine if the risk is worth the reward. For Maddie, like other kiddos with RCDP, life is lived based on quality, not quantity. So treatment must assist in maintaining or improving that quality of life. A prime example of this is our current evaluation of Maddie's need to have open heart surgery to repair a moderate-sized ASD and mitral valve prolapse.
To date, this has only caused mild symptoms or issues in her daily life or illness recovery, but we are at that point of the evaluation that we need to determine if surgery is going to happen or if we're just going to leave it alone and let her live as she currently is. While I know that it is nigh impossible to have a complete cure for RCDP, what her father and I would not give to have a treatment available that would allow Maddie to go through life just a little bit easier, to shorten the recovery time for respiratory or viral illnesses, to allow her body the ability to repair the ASD on its own, to maybe allow her to move just a little bit more to where we don't have to give her a medication to help with her guts and her gut and bowel regimen. Or maybe, just maybe, give her a slightly higher cognitive ability and hear her say mama or dada just once. For Madeline, her brother, and us, that is what an ideal treatment would be to help improve her life living with RCDP. Thank you.
Thanks very much, Jen. Very, very moving. And our next speaker is Teresa Kreisel.
Hello, my name is Teresa Kreisel, and this is my son, Aspen. We are from Sharon, Wisconsin. Aspen has 4 other non-affected siblings, three older, what did I write here? Hold on. His 4 other non-affected siblings. He's older and younger. Today, Aspen is miraculously 12 years old, and Aspen has RCDP type 1. We didn't know that Aspen had RCDP until he was about 3 months old. Overall, when he was born, he was healthy. He cried a lot, but overall was healthy. We noticed that his arms didn't seem to move much, and they looked like what we call laid onto his side or on his tummy and didn't move much. I ended up taking Aspen to our nearest children's hospital an hour away, and we spent a full day in the ER having x-rays, blood work, urine samples, x-rays, and hours of waiting to be met at the end of the day by the on-call geneticist, who told me Aspen had some form of bone disorder, but they weren't going to tell me what they thought it was until the genetic testing came back. They didn't want me going home to Googling what the possibility could be. Some were severe, some were not so much. We waited several weeks to then be met with our RCDP diagnosis, and then we started the multitude of referrals. So first, Aspen was diagnosed with cataracts. Initially, it was feared he would lose his vision completely due to the fact he had not been diagnosed until 3 months. Aspen was immediately scheduled for cataract surgery, 1 on each eye with 2 weeks apart between surgeries. Surgery aftercare for that included daily eye drops, an eye patch to help one eye get stronger, and then ultimately being fitted for contacts and glasses, which he wears daily. The second area of importance for Aspen was nutrition. I nursed Aspen until he was 19 months old. However, to help him gain weight, he needed to supplement with high-calorie formula to guarantee he was receiving extra calories and additional nutrition. After Aspen's first birthday, he transitioned to an older formula until he became intolerant of that around 5. After much research, I transitioned him to blended foods. I blended daily for several years until our medical insurance was able to provide him some blended packets, which really helped facilitate his nutrition while he was at school. Eventually, as we got older and insurance things changed, insurance was able to give us a whole month's supply. So for the most part, that is what we currently do. And then sometimes we blend just because he likes different foods. Aspen also just had a swallow study to ensure that he is not aspirated and that he can continue to eat safely. Aspen continues to slowly gain weight and is currently 29.15 pounds. And although these were our main and first focuses, seeing all sorts of doctors, pulmonology, cardiac, speech, language, hearing, ENT, neurology and neurosurgery, who keep tabs on seizure meds, orthopedics, who see him often, and keep tabs on his x-rays and MRI to keep a close eye on his cervical stenosis, kyphosis, and scoliosis. He wore a helmet for his flat head when he was little. He has worn AFOs to keep the positioning of his feet corrected. He also has a back brace to help with his scoliosis, which he does not love. Eventually, we also hooked up with physiatry and the special needs clinic and a dentist. When Aspen was quite young, he had dental surgery to remove his front teeth that were rotting and to add caps to his molars. Today, Aspen has a clean bill of dental health with no cavities. Aspen started physical therapy, occupational therapy, and speech therapy with the Birth to 3 program when he was 4 months old, and has continued with all these therapies with the addition of vision therapy at school and at home ever since. We also completed a short stint giving him krill oil to increase plasmalogen levels. However, that was short-lived due to phytanic acid levels rising higher than doctors would like to see. Priorities for Aspen for future therapies would be GI and muscle tightness. One of my goals have been to avoid the need for a feeding tube, and so far we've been able to do this. I would like to see Aspen continue to receive his food by mouth because he really loves the different flavors in eating. So I pray that this will never be taken from him. His tight muscles hurt. He hates when I do physical therapy with him, and they prevent him from doing things he would love. Other areas that would be high priority for future treatments would be overall growth and better lung function. These kiddos are so small and have such small lungs, they are easily susceptible to lung and respiratory illnesses. We are looking forward to what the future holds for RCDP, not just for Aspen, but for the future generations of RCDP kids. Therefore, we continue to go to Delaware every 6 months to participate in the natural history study.
Thank you very much, Teresa. And our final speaker in the panel is Melinda Holliday, who will be coming to us virtually.
Hello, my name's Melinda Holliday. Our family is from Alcaloo, South Carolina. My husband and I have 3 boys, Taylor, Landon, and our youngest son, Ethan, who just turned 17, was born with Rhizomelic Chondrodysplasia Punctata type 1. 17 years ago, there was very little information on RCDP, and what we did find was very outdated and crushed any hope for a future. We eagerly sought out any doctor or specialist who is familiar with RCDP and could offer us any semblance of hope. I can honestly say that in all of our years of searching, we have never found a doctor who has ever seen another child with RCDP. Ethan sees every specialist known to man and has since he was a baby. My hope was that we would never need all of the specialists, but I always wanted Ethan's doctors to know him at his baseline in the event that there was ever a time that he needed intervention. Of course, at that time, we had no clue the pain and uncertainty that the future would hold. We have experienced so much over these past 17 years that it is truly hard to put it all into words, but I will try my best. Living with Rhizomelic Chondrodysplasia Punctata has changed everything about how we live. Along with the diagnosis came cataracts, hearing loss, joint issues, feeding issues, heart issues, bone deformities, spine issues, bowel issues, failure to thrive, seizures, infections, pneumonia, respiratory failure, compromised immune system, pain, extended hospital stays, which is where we are now. And little by little, all of these things have taken away from our ability to live life outside of this diagnosis. Ethan's weak immune system, the enormous amount of medical equipment, and just Ethan's health in general make it challenging to even leave our home on any given day. Ethan takes 4 different seizure medications to control multiple types of seizures. We have received an additional diagnosis of Lennox-Gastaut syndrome in the past few years, which is a seizure disorder that encompasses all types of seizures. The seizures are controlled as best we can, but medications make Ethan lethargic. They make him experience sleep apnea episodes, and they have robbed Ethan of his sweet smile and the ability to live his life to the fullest. Ethan sleeps most of his days away, and we wish greatly that the medications do not affect him the way that they do. But how can we choose between the medicines that control the seizures or a more aware Ethan? There's no choice, especially after we have watched the seizures ravage his body time and time again. Ethan's lungs have also been greatly affected. In August of 2023, we made the hard decision to have Ethan receive a tracheotomy. It was a difficult decision, but we knew that after 3 separate incidences of respiratory failure in the last 3 years, we were at the point that we had no other option. The trach has allowed us to treat Ethan at home when he is sick, not be admitted to the hospital as much, but we still have to do daily nebulizer treatments that take 1 hour, twice a day, to keep his lungs as healthy as possible. We know that one more bout of pneumonia or one more collapsed lung could mean the end for our sweet boy. We have searched a long time for a treatment form, but there have been no safe or FDA-regulated options. We are very cautious with anything we give to Ethan, whether it be medication or food. We are looking for a safe treatment that can help make Ethan's life better. We don't expect a cure, but we do hope for less seizures, better respiratory health, and a better quality of life all around. Ethan deserves a chance to have the option of a safe treatment and to have the chance at a better quality of life. As his parents, we deserve the chance to live life with Ethan outside of the walls of our home and be able to watch him thrive instead of suffering. And his brothers deserve to be able to lay their head down at night without the fear that tomorrow may be the day that their brother dies. Every child deserves a chance to live, not just exist. And that is all that we want and ask for our sweet boy.
Well, we do thank Melinda for her insights and know her attentions are very importantly directed elsewhere in the hospital there, as many of you have experienced on numerous occasions. So this gives us such important insight as to what is not working about current therapies. So we're now going to broaden the discussion with other members of the audience. To do that, we'll start with a series of polling questions. And for those of you who are with us for the morning session, you can go back to that same webpage. If you've just joined us, we can go to the screen as you see before you, scan the QR code, or you can go to your browser and choose www.POLLEV.com/RCDP PFDD. Almost no vowels in there. Sorry about that. So again, you can go for the remainder of the day, as we'll be coming back with questions periodically. So as a reminder, please only submit one polling response per person, per patient with RCDP. If, for example, 2 parents are here on behalf of 1 child with RCDP, only one of them should vote. And this is just to give an equal pairing. If they're representing 2 children with RCDP, they can both vote. So if folks are on with polling question number 8, has your child ever taken or received any of the following treatments, medications, or experimental drugs to treat the symptoms of RCDP? Please select all that apply. So you can see the choices there. Alkylglycerol or plasmalogen, supplementation, dietary restriction of phthalic acid, medications to manage pain, anti-seizure medicines, or other. Lots of other. We'll give it a moment to process in. And we'll definitely come back to those of you who responded with other to get some additional details. It would be important to talk about as we get to the discussion most and helped with which seizure is obviously directed appropriately to seizures, but medications to manage pain were there particular types of bony pain, headaches, what have you. Any questions or concerns or comments there? Okay, if not, let us proceed with the next polling question, which is number 10. And you can start anytime you're ready. And when considering a new treatment for RCDP for your child, which considerations would have the greatest influence upon your decision? Longer span of life with same symptoms, fewer physical symptoms with same lifespan, or fewer neurological symptoms with same lifespan? So I'll give you a moment to respond there. And sorry, I jumped ahead to the. Good. Everyone had a chance to talk about. There's the spirit with both of the lower two options is to try and improve as much as possible the quality of life neurologically or physically for the children, as opposed to just prolonging. So that's helpful to drug developers and others in terms of understanding how to target interventions. It also helps in how one designs clinical trials to identify endpoints that are meaningful to you as caregivers and your children. And that was polling question 9. I think and these are difficult trade-offs to make, aren't they, for any type of situation, but especially with these when you're talking about age and stage of life. So to move to polling question 10, unless there are comments here or questions? No? All right. If we can. And I believe this is the last time we'll have to pick on your thumb power for a few minutes anyway. Considering a new treatment for RCDP for your child, which consideration greatest influence on your decision? And you may choose up to 3. So the chance of rare but serious side effects, chance of common but less serious side effects, cost of treatment, frequency of treatment, distance and time to treatment site, and finally, physical burden of how treatment is. That could be intravenous, in some cases by other routes in other rare disorders. Give you a moment to choose. Not usually we get 3 choices, other than at a Chinese restaurant, I guess. And it's no surprise that many of you immediately went to the chance of rare but serious side effects. Those are the things that always test our judgment of trading off possible benefits with risk tolerance. How much are we willing to tolerate that may be dangerous for what level of advancement for the well-being of our children? It could be a pretty big payback. And especially for things like neurologic diseases, for example, the physical burden of how treatment is administered, sometimes that is given not only intravenous, but sometimes there are several medicines now given into spinal fluid and so forth. They can be very effective, but that obviously raises different questions. So it's just not a black and white answer, but something that we all must consider for our children and grandchildren. And the choice, chance, if you will, of common but less serious side effect, it's always a consideration. We appreciate as well the cost burdens that come with that. Does anyone have any other specific comments here? If not, then this is an opportune moment to switch gears. We've now polled. You provided us information that complements the meeting survey. And now we have the opportunity to talk about views on approaches to treatment and current treatment as well as future treatments. So there's what we'll call the high five here, the 5 questions to address. And I think rather than going through the entire list, I'm going to take them one at a time and see if folks have any particular comments. These are the topics we're hoping to draw out for discussion, and we'd especially encourage those of you who have not had the opportunity to contribute commentary, please do so that everyone's input can be gathered and appreciated and valued. And the first question there is, what are you currently doing to help manage your child's RCDP symptoms, and how has the treatment regimen changed over time? And we'll find as well as those in the room and those on the panel.
Yes, Tim, we have a comment in the room.
Lovely.
Hi, Elias's mom, about what we needed to do. So he receives OT, so occupational therapy, physical therapy, and speech or language therapy every week. And then he has vision therapy and developmental therapy, which is kind of all encompassing twice a month. We have seen so much. So we've seen him progress with arm and leg movement, but a high majority of the things that we're doing are just preventing contractures, we're starting to get things like he has a structured vest to keep his kyphosis in his lower back from progressing. We're looking into elbow and knee braces to keep those contractures from getting worse. We're also considering AFOs for his ankles. So I feel like the next steps that we're doing for him now are more preventative to keep the range of motion he has. In vision therapy, we're trying to come up with ways. I don't know what he'll be able to do in ways of communication. He already tells us what we need to know in the way he cries and talks, babbles to us, but we're trying to open up his world of communication and give him all the tools he can have in the future if he does have abilities to express himself. So we're looking to eye gaze monitoring or eye gaze equipment for him with our speech therapist. So we're just trying to open up his world to him while also maintaining all the skills he's gained through physical and occupational therapy. And now his arm through 6 months, 7 months of occupational and physical therapy go up almost to his head. We're working on extended
Mention.
Another comment in the room.
Hi, this is Betsy again, Caden's mom. Just wanted to comment specifically the common theme among many of the children are seizures. One of the things that our family has done is we have explored in Washington State, medical marijuana is legalized, and he has been using cannabis to help control some of his seizures. They're not controlled, they still happen daily, but cannabis has been the only thing for Caden that has lessened some of the frequency of his seizures. So we've tried six or seven different pharmaceutical medications. We've tried a couple of non-pharmaceutical therapies, ketogenic diet, a VNS device. None of those have really touched the seizures. We've tried hemp CBD, which is non-cannabis. And then the only thing that's ever touched it is cannabis. So when you're talking about treatments, I didn't want to jump into the cannabis world. I was lucky in our area because a little bit more further into research. There's very, very little research on cannabis and what it can do to seizures. And there is a wealth of information and a lot of possibilities across different diagnoses, not just RCDP. So one of the treatment options that isn't explored very often is just the ability for the medical community or cannabis community to be able to just research and provide that, which doesn't exist right now. So just wanted to put that out there as a thing we're doing and one that could potentially help more people if there's more information out there about it.
Thank you, Betsy.
Thank you for that comment. And there's actually one cannabis-derived medication that is approved. I believe its name is Epidiolex, for a very narrow range of seizure disorder. But I would imagine this is going to be one of those things that people need to look at in clinical trials. But one more tool in that toolbox for what's a very complicated matter to manage.
A little bit, but natural cannabis is effective in a very different way. You can have a whole day discussion. Research with natural cannabis is more specifically what I was trying to get a point across.
Thank you for that. Other thoughts and comments, and I'm just checking on my text messages here, not because I'm ordering groceries, but because my colleagues are sending me messages from what's online. And any additional comments? Disease drug development. It is so important to understand the range of variability in patient progression and how that can serve as the yardstick against which. So the information you provide is very important. We did get one comment here online from Melinda. Says we see specialists every 4 to 6 in control of any given issue. So others that would care to, we can move on to the second question as well. We don't want to necessarily dwell. The second question is, how well does your, and what isn't? So anyone care to step out on the risk curve here and comment?
Any comments in the room?
Thoughts?
Oh, yes, we have another comment.
Great.
Yeah, I guess it's just kind of part 2 of my last comment. All of the things that we do for Elias are mostly preventative. I feel like we mentioned before, we're just treating the symptoms of our CDP. And I feel like John and we have a fairly, I don't know, compared to other families, I feel like we have it pretty easy, but my day-to-day life is still solely around Elias's care. I know it's not super specific, but I hope it's helpful.
Yes, thank you so much. And I also want to be sure that everyone in the room or online has had the opportunity to offer commentary. So inviting those who yet to speak to feel in, which is, what are the most significant downsides to your child's current treatments, and how do they affect their daily life? So what's not working the way you'd like it to be working, and how does that complicate your all-day activities? Comments?
Yep, we have a comment. One moment.
Great.
I know Melinda had mentioned this about the seizure medications. Jude had, for a while, he was having like 30 to 40 seizures a day. Some of them were mild and very short, while others would take us to the hospital and cause his oxygen to tank and all kinds of things. So we've had to put him on different seizure medications. He's unfortunately allergic to seizures worse, like way worse. So we then found out he can't have like any of those rescue meds. So now when he has a seizure that's lasting longer, we actually have to give him a double dose of his seizure med, the one seizure med that he can tolerate. So I think our fear is always like with Jude's epilepsy, like if his seizures continue to get worse, what can he take? That's been a big concern for us. And then, like Melinda had mentioned, it's also really hard that some of Jude's medications, we feel like kind of takes away from his personality some days. You know, when we have to medicate more for seizures, it's like his personality isn't there as much, and that's been emotionally taxing to not see him smiling as much as everything in the world is when we pick him up and dance with him and sing with him. And sometimes that excitement can actually cause a seizure as well. So that's, it's been a challenge trying to figure out how to manage Jude's seizures while still keeping Jude's personality intact.
Thank you. And this is a good opportunity to invite panelists who wish to add to comments from panel 1 or panel 2, because all inputs are important. There's one here from Melinda, which she writes, we started with 1 seizure med and are now up to 4. Ethan takes 6 different nebulizer treatments twice a day, and that's just preventive. Much more involved when he is sick. So even the baseline I know is so challenging for you all, but then when there's a flare up, undue excitement. Other thoughts and comments on these downsides?
Yes, we have a comment here.
Hello, Jake and Jordan's mom. Horrible seizure thing for 22 years. There's pros and cons to the seizure medicine. The con with Jordan was there's side effects, and you don't know until you continue to take them what side effects can happen. First of all, with the it's different. Don't freak out if it's like, that's my seizure med. So all kids are different, but Jordan was on Lamictal, and she kept having more seizures. And they said, oh, well, we need to go up on the Lamictal. So we continued to go up on it, and she was having more and more. So that caused her to have more. As they went up on a certain seizure medicine that wasn't for her. She was on Onfi, and Onfi, it's good for some kids. It wasn't good for Jordan. She was zoned out. Her tongue was always sticking out. Her eyes were closed. She had no personality whatsoever. But the scariest one was zonisamide. Zonisamide is a seizure medicine, and it can cause kidney stones, which now I know a lot of the kiddos are starting to get kidney stones. And Jordan, it caused her to have 4 kidney stones because of the zonisamide, and also it's hereditary if it's hereditary in your family. So it's been a struggle to find the right type of seizure meds. And as the kids get older and they get heavier, we've like reached the highest that we can go on the seizure meds. So that's kind of challenging too, because you don't want to see them keep having seizures, but you don't want to play around with a lot of medicines either. So.
Thank you very much, Matt. And I guess it reflects on what we've heard from some of the others as well. And I kind of scribbled down here, trial and error terror, that there is this always issue of not knowing, especially with anti-seizure medicines, will it work or not? And then you have to go to another trial and error. And even if it works, does it bring on adverse events, drowsiness and so forth, that complicate therapy type longitudinal plan for long term. Thoughts, comments?
And talk about like eye health. So for Aspen, I put contacts in his eyes when he and his eyes tolerate it. So it can be a little challenging trying to get contacts in. But it's so funny to see like when he has his contacts in and his proper glasses on, it's just times where he didn't wear his contacts because his eyes just kept getting red and gunky and yucky. He has other glasses for those times, but they don't fit his face very well. So, and you can tell like his eyes don't open as bright as like when he has his proper contacts and glasses on. So it's just a struggle in that world for us.
Thanks very much, Pat. And it may lead nicely into the next question, which I'm guessing many might wish to comment on. I'm going to add a little twist to it. Assuming there's no near-term complete cure, what specific other way, one thing. I know there's many that are ongoing. What would that one thing be? Be interested in your thoughts.
You have a comment here, Tim?
I think for us, it would be lung function more than anything, just because he just gets like any kind of like the flu, or just because his lung function tanks, gets the common cold or the flu or anything.
It's understandable those kind of things cause great worry and be a great relief to the child as well as to the parent.
We have one more comment here in the room.
I think for John and I, one of the things that we hope the most for Elias is having a clear-cut way of knowing how he's doing, and he could tell us like what's wrong. So I think for me, just improvement like on cognitive communication abilities, that's one of the things that is like my ultimate wish for our kids.
Great. And I'm looking here online. Please.
I'm Jim Brown. I'm George's father. I was going to say virtually the same thing with one caveat. I got 6 kids. Be careful what you wish for when you wish they could talk about.
We have another comment in the room, Tim.
I'm Ashley, Nathan's mom. For Nathan, his father and I really would like to see improvement in his mobility. His limb shortening really impedes what he can do in simple acts that he cannot do, like dressing. Dressing is so hard, putting shirts on him, because his arms can't lift. And like I said before, even the simple act of scratching his nose, because Nathan has an NG tube, not a G tube. And sometimes it bothers him, and sometimes we don't see when it bothers him. Putting him in a car seat, we have to put cushions in it. And, I mean, we're breaking all the DOT safety laws in order to make sure that our kids are comfortable while traveling, even if it's just to go to the grocery store. But I would say, that's important to us, but also, seizures, because he gets terrified and he screams. It's frightening to him. It really is. And that's so scary for us. And it breaks our heart. It truly does, each and every time. And that's really all I have. Thank you.
Appreciate that. And, you know, it does bring up an interesting twist for all of these, wish it could happen. Is there any relationship to participating in clinical trials relative to that? That in the desire for trial interventions? I think on the pre-meeting survey, there were, I don't recall anyone had responded positively to have been in clinical trials. So that's, you know, something that's kind of the next graduate to with folks who are doing development, with interfacing directly with FDA. We've had that one can look at as ways to graduate to the next level of impact. Thoughts, comments?
So when we were first diagnosed and we were learning more about RCDP, there were basically two things for Keaton that they said were off. He had high phytic acid levels and he had lower than normal plasmalogen levels. He said, okay, well, phytanic acid is something you take into your system, so that's something that you can control. So ever since then, he's been on a low phytanic acid level diet, and currently he is within a normal range, same as most of us in this room, of phytanic acid level. So then my next question, of course, was, all right, well, we can control that if he does 17 years ago. So if, and of course, now we've all learned, and with Dr. Bober's information earlier, I would give his body the ability to have plasmalogens. I would give his body, his cells in his body, the ability to complete that process so that then as a subsequent subset of that ability, maybe the rest of his body could do the things that it's supposed to do. That would be my wish.
Certainly an interesting observation, and being able to replace deficiencies. There are a lot of developing strategies for that across a number of rare and ultra rare diseases. So pretty interesting. Last question, which we have yet to touch on, but I think it would be interesting, especially as you share across the parent communities. What factors do you consider when making decisions about selecting a course of treatment? What do you weigh in terms of benefit, of risk, and so forth? That sometimes you get caught in more had a chance to think about how would I weigh these various factors. So we certainly understand that's a challenge, but any thoughts about how you would structure trading off benefits and risks and making the decisions if you were posed with a new opportunity, a new trial, or a new treatment?
We have a comment.
Becky.
One moment.
Well, having a long-term survivor with RCDP, I vote for the quality of life. Live. So if the quality can be better, let's go for that.
Me again. I believe I touched base on it a little bit in my speech. With our current evaluation of what we're having to do for Maddie is evaluate if she is going to have open heart surgery to repair her ASD. Because she is so small, they can't go in femorally. They have to cut her chest open to repair it. So part of making this decision is looking at all aspects of it. Will the surgery, will the repair help her? Yes. Yeah, it'll help her. Is it negatively affecting her right now? No, not really. But then we also have to look at the complications that come with the surgery. So yes, the solution, let's repair the hole, but how we do it is what we really have to look at. It is the invasive surgery. It is the recovery. It is the risk of infection and the high risk that she'll go in and not come out. So decision of the risk versus the reward, and what is it actually doing to our child? Is it that acute life decision where they are in that acute condition and you have on the medical experts in that moment, or just that full evaluation of the situation.
These are difficult decisions and they get more complicated with time. You raised the point of just having the burden of being in hospital and the distraction that creates for your child as well as for the entire family. It is really a stressful situation. Other thoughts or comments? Well, I have two things to add. If there's, as I know we're getting close to the bottom of the hour, and I don't want to break a promise to you. Three thoughts to add. Number one, when I was in patient care, and it follows on with the comments just now, I would tell patients there's no such thing as a bad question. And when you're in an uncertain situation and don't understand something, it's always best to query. Second thing, I was struck by several of your comments that as a child's resilience declines, it becomes important. I need to ask. And I got a note from Sanjot that we have one more comment in the room, and it's much more important to hear your comments than mine. So please go ahead.
The questions that have come up. So before it seems like we're starting to wrap up, so I'm going to gather my thoughts. With all of the various interactions that we have with the medical community, the thing that seems to be consistent with across all the specialists is the fact that they don't really know what to do with us because they generally ours. We're always the first. Oh, I've never seen this diagnosis. So even if we're going to the genetics department, oh, I've never had a child with RCDP. I've never had a child like this. So there's always a question mark of, do I even trust this medical person to help me with whatever solution that they're offering to me, because they don't necessarily understand the whole picture of how it might affect, because nobody in the world really does. So as a parent, that's something that's always the top of mind when you're thinking of something, is that they don't know, because nobody knows. The most poignant example that I can give in our journey is, I had mentioned in my presentation earlier that Caden was diagnosed with lymphoma. And it was actually the first time that a medical team, we'd been given a diagnosis and the medical team said, here's his diagnosis, here's a treatment plan, and we can fix him. Except for when they said, in a typical family, we would say there's about an 80% chance that he's going to react to the treatment and he'll be okay. But your son, we have no idea how his RCDP is going to affect the treatment. We don't know if it's going to work the same way because his body functions in a different way. So even with something that has been a tried and true treatment, they don't know. They don't know. So more treatments, more research. Like, one of the things that we all enjoy learning and appreciate is the fact that there are researchers in the US and Canada, around the world, that are trying to learn more about plasmalogens and are trying to learn more about what they do and how the body functions with them. So one of the things that a medical doctor, they know more. They can't say, I don't know. They can say, we understand how this functions in the body and it's going to happen this way, and we can give you that information. So that's just sort of a global medical thing of what we're dealing with all the time and what could be better if there was more information out there. So just wanted to make sure to get that in.
That's a great opening as well as a great comment to say what we're creating here as a community is an enduring record that FDA and others will be able to refer to. So if anyone else has any additional comments, we can certainly run over, and it gives you the chance to at least put something in that record that you feel is important, something that would help those in the future as well as what happens in the present. So the door's open for that. Before I pursue some closing comments,
We have
I know you're probably tired, and you're probably tired of hearing my voice.
one more comment here, Tim.
Lovely.
Hey, my name is Tracy Thomas, and my son Jackson was 5.5 years old when he passed away. He had RCDP type 1. And just the thing that I wanted to stress was I don't think anybody can ever prepare themselves for this journey. And that's preaching to the choir in this room. But when you have a child born with a rare disorder, you just automatically assume that somebody else has come before you and paved the way, and somebody else has already started an organization, and surely somebody's developed a drug, and there's a treatment, there's a therapy. And then when you realize that you're in an ultra rare community and that everybody together is kind of paving a new path to get where we all want to be, it's very hard when you hear things like a therapy would be, 10 years out at least. We're that far away from a therapy or a treatment of any sort. And what I want to say is too, I don't think anybody's ever prepared to basically have a child that requires the amount of care that an infant requires their whole life. It is exhausting, and it takes everything you have to do that, to give that child the care they need. But then that is one of the problems with why it's hard, is because you want to give as much effort into creating an organization or putting as much effort into moving forward with research, but you're putting everything you have into taking care of your child. You're just doing the basic day-to-day. So I have a lot vested in this, and because when we first started and the doctor said, you're at least 10 years out from a therapy or a treatment of any sort, we're 16 years out now, and we're still waiting, and we're still working, and some of us have lost our children in the meantime. But we're still working because we've sat in the shoes with these parents that still have children that are waiting, and it's still that important to us that it continues. So what I want you to know is we're still working for this, even if our children are not going to benefit from it, because we know these other children that will benefit from it. So we're just hopeful that we can move forward this time, but it is a hard life, and I don't think anybody's ever prepared for the financial, the emotional, the physical, the mental strain that it takes, the anxiety that you have to live with. So it is just very much my hope that we are at a juncture now where we are moving forward, so that these kids that are still waiting have this treatment, this therapy that we've all worked so hard for. So thank you so much for the time today to share that.
What a wonderful way to put a summary together to be able to really enliven the discussion and continue it. I'll just ask if there are any additional thoughts or remarks.
Yes, we have one more here.
I was trying to wait till the end, but I was asked several times at lunch if I was going to say anything. Of course, I'm Abigail and Jacob's mother. Both of my children are angels. I'm so very thankful to be here. So way to honor them and honor their precious lives. And I was one of the original 5 parents, and Abby and Jake were one of the original 7 kids. And we have participated and done all the things. Abigail took krill oil too. It was of no benefit to her. We also looked at, I had to write it down because I knew I'd get up here and forget. Beta alcohol they were using in the Netherlands, and we were willing to go there and receive the treatment, and they decided it was ineffective and not crossing the blood-brain barrier. So I think in the 16 years, we've learned a lot about, having hope, but also being realistic of maybe it would fix something, but not fix everything. So we're really praying and believing that this is the time, 16 years in, that we're going to be successful. I did give Abby Charlotte's Web CBD oil for seizures because she had some mild seizures towards the end of her life that none of the seizure medicine was really effective with. Abigail was not born with cataracts. Both of them were type 1. But when Abigail was born, Vanderbilt and Nashville had never seen RCDP and told me that she just had a form of chondrodysplasia and she'd be fine. And then Little People of America Conference told our geneticist they thought it was RCDP, so we did the skin punch, and Jake was diagnosed in utero. So we did do intraocular lenses and then contacts and glasses and things for them. But I'm thankful that everybody's here. I'm thankful for the progress we've made. I'm thankful to honor my sweet, precious babies' lives. And of course, I know things have changed a lot. Abigail didn't have a feeding tube until she was almost 6. Jacob never had a feeding tube. So I'm open to any discussion if I could be of any benefit to helping figure something out for anybody.
Again, our thanks for really being able to share the journeys. It's so important. And let me congratulate you all for amazing resilience and also advocacy for a better life for your children amidst such challenging circumstances and complexities. Any final comments before I try to tie a ribbon on what's been an amazing day? Thoughts, comment? Well, if not, let me say thank you to each and every one of you who've contributed to this dialogue today and shared through panels, through polling, and through the live discussions. We'll be incorporating all of this feedback into the Voice of the Patient report that will be published in a few months, which FDA, developers, and other potential stakeholders will use as kind of their Wikipedia or medical Bible for RCDP as a very valuable reference guide. This is something that did not exist before, and it is a springboard to the advances in therapy and trials. So we're really grateful for all the personal insights to help all better understand RCDP and its impact, as well as capturing what you've shared about unmet needs, desired benefits, risk tolerance, and how all that fits into a Voice of the Patient report, which FDA again looks at because their final scales of justice, if you will, for approving new products is benefits exceeding risks. So that becomes very important, and you have contributed that. So thank you to our clinical speaker, Dr. Michael Bober. We're really grateful for the work that he and colleagues do every day to help children with RCDP. I thank my colleagues, Dave Zook and Sanjot Sangakkar, for all their tremendous work, and Dave's commentary, as well as Sanjot stepping right in on the moderation when we had the electronic gremlins invade us. A special thanks to RhizoKids International, to Melinda, Brian, and others for their contributions here in planning and carry through. This session would not have happened without you. Thank you to our sponsor, MedLife, for Sean, Tara, and Kaylee. MedLife Discoveries helped make this session a reality, and their support has been invaluable. And thank you most of all to all of the RCDP community, everyone who has the courage to speak up during these panel discussions and live discussions, bravely sharing to help each other. That's really remarkable and a distinction for this community. So a round of applause for me to you. A video of today's program will be made available on demand immediately after we conclude on the same link you're now on. So thank you to one and all. It's really been a privilege for me to be able to learn from you and to respect so much what you do for these children every day and every hour. So safe travel, God bless, and we'll look forward to future gatherings when we can celebrate that future progress.